Hello, everyone, and welcome to our module on chest x-rays. So two of the most common requests I get from medical students are, Dr. Ryan, tell me how I can get good at interpreting chest x-rays or EKGs. And unfortunately, the only way to get good at interpreting chest x-rays and EKGs is to interpret them every day or every week or every month as part of your regular practice. Until you get to a point in your career where you're doing that, you are always going to feel relatively bad at interpreting chest x-rays and EKGs, and you just have to get used to that fact. When it comes to chest x-rays, one of the reasons that they are difficult to understand at an early level is that it's very hard to see the different structures. In addition, there are lots of normal variants and there are many pathologic findings. So in my opinion, reasonable goals for medical students are to know basic chest anatomy by chest x-ray and know classic sort of slam dunk examples of specific pathologies. And so that's what we're going to focus on in this video: basic chest anatomy and classic examples of pathology. Let's start by reviewing some chest anatomy. And to do this, let's look at the normal chest x-ray I've placed on the center of the slide. So first of all, if you look closely up here, you can see this sort of darkened straight structure here. That's the trachea delivering air down into the chest. In fact, if you look closely, you can actually see where it bifurcates into the left and right mainstem bronchi, although this is harder to appreciate if you're not used to looking at chest x-rays. Along the bottom here, we have the diaphragm, and you can see a little bubble here. That's air that is down inside of the stomach. And then here you can see the ribs that we've got climbing up into the chest. In the center of the chest, this white thing you see here is the heart and vascular structures. So first of all, you should know that when you're looking face on at the patient, which is the way you're looking at the chest in a chest x-ray, the most anterior structure is the right ventricle. And so that's what most of this white material is right here in the middle of the x-ray. If you look up at the top right side of the screen, I've put a cross section of the chest by MRI, and you can see that the right ventricle takes up most of the anterior part of the chest. So when you're looking straight on like this, you're going to see a lot of the right ventricle. The only part of the left ventricle you'll see is this little piece right here that sort of sticks out at the side over into the left side of the chest. And you can see I've actually labeled that with an arrow here. The left ventricle is sort of over here. The right ventricle is sort of in the middle of the heart structure here in the center of the chest x-ray. Now, as you go upward in the middle of the chest, you start to encounter other borders. For example, this is the border of the left atrium I've labeled here. This is the border of the pulmonary artery here. And you can see part of the aorta called the aortic knob up here. It's very difficult to distinguish these structures from one another by chest x-ray. You have to just know where they sit and how far up they are in the chest relatively. And therefore, when you're looking at one of the borders of the mediastinum here in the center of the chest x-ray, you can estimate what you're looking at, whether it's the wall of the left ventricle, the left atrium, or the pulmonary artery, or the aortic knob. If you go up along the right side of this structure in the middle of the chest x-ray, you find the border of the IVC here. It's next to the right ventricle. And then you find the border of the right atrium, and then finally the border of the SVC. And so once again, I can't emphasize this enough. It's very hard to get good at reading chest x-rays until you do it every day as part of your job. And it's very hard to see all these structures because they aren't easily distinguished from one another the way they are by an MRI or a CT, for example. You just sort of have to know where to expect them when you're looking at the chest x-ray. And as a first or second year medical student especially, they're not going to expect you to know lots of details about chest x-rays. You just need to know where the basic structures sit, and those are all the structures I've labeled on the screen here. So now let's go through some classic chest x-ray findings. These are basic findings that should be able to be identified even by medical students once you know what to look for. So we'll start by talking about pulmonary edema. So this chest x-ray on the left side of the screen here is a normal chest x-ray, and compare that to the one on the right side of the screen from a patient with pulmonary edema. The main finding in pulmonary edema are these fluffy white sort of infiltrates. They fill up all the lung fields on the left and right side of the heart. Depending upon how much pulmonary edema there is, sometimes they go all the way up to the top of the lung, sometimes they don't quite get that far. But basically, it's fluffy white material in all the lung fields on both sides of the chest. That's what pulmonary edema looks like. Now, other things can look somewhat like this too: interstitial fibrosis, which we'll see later, other infectious processes. And it's not going to be easy for you as a med student to distinguish those from pulmonary edema, but you'll know pulmonary edema by the company it keeps. So in a patient who has heart failure and classic features of heart failure on exam and shortness of breath, and you see this x-ray, then that's pulmonary edema. In contrast, a patient with fever and infection, this might be some kind of infectious process. So know that this is a classic example of pulmonary edema, and the way you're going to not confuse it with other things is by the description of what's going on with the patient. One of the classic findings of pulmonary edema on chest x-ray is the presence of curly B lines. These are not easy to identify if you aren't used to looking at them on a regular basis. But you can see they're at the edges of these arrows right here. You can see these straight white lines like this one here. Notice that they're not present on the normal x-ray on the other side of the screen. Those are curly B lines. Those represent fluid in the lungs, and this is a finding you can see in pulmonary edema. Okay, on this slide, I've shown you a classic example of a pleural effusion. So notice that over here on the left side of the chest, you have basically a whiteout of the bottom half to 2/3 of the lung fields. That's what a pleural effusion will look like. It will opacify, in other words, it will turn the x-ray white on the side of the lung with the pleural effusion. Notice that you can sort of see a border of the liquid right here. That's a classic thing to see in a pleural effusion. Notice also that the white material isn't confined to a single lobe. That's what you might see in lobar pneumonia. But here we've got white infiltrate sort of filling up half of the lung or more, not obeying the borders of any particular lobe of the lung. Okay, in this slide, I've shown an example of a pneumothorax, which I talk about in detail in the video on pleural disease. So if you look over here at the left lung here, you can see these little wispy sort of white things, and they stretch all the way out to the edge of the lung fields. Now, if you look over at the right side over here, you can see wispy white things here, just like on the left side, but then they abruptly stop. And actually, if you look closely, there is a line right here, and it's all dark out here beyond this line. There are no little wispy white lines. Those lines represent lung tissue, and the reason there aren't any over here is because this person has a pneumothorax. So there's a hole in their lung and the lung is collapsed. This is the lung tissue down here. That's why it sort of looks normal, like what you see over here. But out here in these areas of the lung, you're not seeing any of it. These are easy to miss if you don't look closely. They're not something that jumps off the slide at you. But even as a med student, if you look at 2 or 3 examples of a pneumothorax, you should be able to become skilled enough to identify the border of the pneumothorax and recognize that there's no discernible lung tissue sort of out here beyond the border of the lung. Okay, here's an example of a right upper lobe lobar pneumonia. So notice that we've got white infiltrate here, but it's confined to the right upper lobe. It stops right here at the border of the right upper lobe. You don't see any down here in the right lower lobes, and you don't see any of it over here in the left lobes. So this is a consolidation. It's basically pus filling up the right upper lobe, and this is a classic finding in lobar pneumonia. And in the videos on pneumonia, I show you some examples of all different lobar pneumonias in the different fields of the lungs. Okay, here's a chest x-ray showing interstitial fibrosis. So notice that you have fluffy white infiltrates streaking out through all the lung fields and filling the lungs all the way from top to bottom. Now you might be thinking this looks a little bit like pulmonary edema, and it does, and distinguishing interstitial fibrosis from pulmonary edema is not easy to do until you get some more experience looking at chest x-rays regularly. At the med student level, the way you'll probably distinguish interstitial fibrosis from pulmonary edema is by looking at the characteristics of the patient that the image comes from. If it comes from a patient with a years-long history of chronic pulmonary disease, then that likely represents interstitial fibrosis. This is a chronic process that develops over years. On the other hand, if it's from a patient who has a history of heart failure, who acutely became short of breath a day ago, then that probably represents pulmonary edema. And trust me when I tell you this, throughout training, even at the intern and resident and sometimes attending level, you will always use patient clues to interpret images. There are many different findings on images, whether it's X-ray or CT scan or MRI, that can look alike. And much of the way you tell one from another is by knowing the history of the patient to know which finding is more likely. Okay, here's an example of hilar lymphadenopathy, which is enlargement of the lymph nodes at the hilum, which is the area on the right and left side of the mediastinum in the chest. So notice this fluffy white material right here. This is over on the right side of the chest, and you've got another fluffy white area right here over on the left side of the chest. When you see these fluffy areas, one on the right, one on the left, they're bilateral, that's hilar lymphadenopathy. This is a classic finding of tuberculosis. It also occurs in sarcoidosis and some other conditions, but the 2 conditions you definitely want to remember for hilar lymphadenopathy for your board exams are tuberculosis and sarcoidosis. And then finally, I'll finish with an example of a pulmonary nodule. It's fairly easy to see in this image here. There's this white spot here in the right upper lobe. This is the kind of finding you can see in someone who has a lung cancer. It's also the kind of finding you can see in someone who previously had tuberculosis or some other lung fungal infection. Those can leave behind scar tissue that can form a pulmonary nodule like this. The workup of a nodule is complex. It's not something you need to know at the early med student level, but you should be able to recognize if you're given a very obvious image of a pulmonary nodule, what you're looking at, and know that that likely represents some type of underlying disease process, whether it's a lung cancer or a prior healed infection or something else. And that concludes our module on chest x-ray.